Good evening, everyone, and we appreciate you joining us for a wonderful live stream as we think about Prostate Cancer Awareness Month. And you are now live with Couch Conversations with the Doctor, where we will share our perspective and answer questions. So, as we have this conversation about prostate cancer, please ask any question you would like of this panel of doctors and congressmen and experts like my friend Joseph Harrington, who also has a very nice perspective. So let's get started. I'll just start with Dr. Graham. Would you introduce yourself, my friend?
Thank you, Dr. Tony. I'm a retired physician. I worked in the western suburbs as a specialist for 30 years. And after retirement, I joined Representative Davis in his office. And it was an amazing and educational experience. It's a real honor to be here with my colleagues. I'm going to try and answer your questions as best I can.
We appreciate that. And let's circle around and go to Joseph Harrington. Introduce yourself.
Thank you, Dr. Tony. Well, my name is Joe Harrington, like you said. I've got an interesting background. I've worked in 4 different fields, starting with mental health and education. Then I went into public health. Actually, when I was in mental health, I was in public health because I worked for the City of Chicago Department of Public Health in a mental health center. But mental health, moving on, did most of my work in public health and healthcare, retired in 2017 from the Illinois Department of Public Health, where I was the administrative regional health officer, excuse me, for Cook County and an administrative law judge.
Thank you. Appreciate that. And Dr. Miller, would you introduce yourself?
Yeah, good evening, everybody, and glad to be able to join this forum with my esteemed colleagues. My name is Dr. James Miller. I am also a retired physician. I'm a retired internist. I retired in 2019 after practicing approximately 41 years in internal medicine throughout Chicago and in the suburban area. And even though I don't do clinical medicine anymore, I'm still interested in healing our community. So I'm here tonight to do whatever I can to have some input on improving our healthcare.
Absolutely. And Dr. Pete.
Hey, Dr. Hampton, and to the congressman and Nikki, our good friend and colleague, thank you for creating this space for us to educate our community. I'm happy to be here. I'm an internal medicine physician, came up in the south side of Chicago, went to Xavier University in New Orleans, HBCU. Recently, we lost one of our icons, who was our pre-med advisor, Dr. J.W. Carmichael, who shepherded a lot of Black physicians out of Xavier. He's gone on to be with the Lord, and I'm just thankful. My line brother, Dr. Hampton, over here, we came up, we got it out the mud, and, in the words how the kids say, so I'm happy to be here, happy to share with the community about prostate cancer and how we can better allow our men to be healthier.
Absolutely. And definitely shout out to Dr. Carmichael. Xavier produces the highest number of African-American doctors in the country. And he was one of the most pivotal. I mean, he really was a big part of that whole foundation. And his very flamboyant personality, I'll never forget. But he made sure when you left that place, you knew what you needed to know. And that's why we all were able to then go on to be doctors. So we'll miss him and celebrate his life. So, Congressman, there's a rumor that you just celebrated something. So I wanted to tee it up with that. Why don't you tell us what you're celebrating?
We see you, Congressman. You got the fresh cut.
That's right.
Well, let me tell you, I did, in fact, celebrate a birthday. And I've had 3 birthday parties in the last 3 days. They've all been great. They've all been wonderful. They've all been good. They went all the way from grassroots to the 44th floor of one of those high-rise hotels downtown on Michigan Avenue. So we've had a ball. But I've also been celebrating Joe Harrington, and Dr. Mason and I celebrated the Life Saturday of an outstanding nurse and nurse practitioner, a great leader. We were all at her homegoing services for Margaret Davis, who at one time was president of the Black Nurses Association. But Margaret was a tremendous organizer, had one of the sharpest minds I've ever interacted with, was a great strategist, and of course, she was well trained with a master's degree in nursing, but she also was a nurse practitioner, and she headed up a large consortium that provided health services on the south and far south side of Chicago, although she lived in the North Lawndale community on the west side. So all of those who knew her knew that she was just a great health provider. I'm also celebrating the fact that last week, the federal government started distributing $400 million, which came from my MACV program that we passed the year before. That's the maternal and child health program that deals with home visiting, where health workers go out and visit young parents, new parents, low income parents, and help them do those things, pregnant women, that are necessary to give their child or their children a healthy start in life. And so we're celebrating that because those $400 million are being distributed as of right now. Agencies that submitted grant proposals and got funded, they've already gotten their money, some of them last week. Others are getting their money this week. So celebration is in order. Thank you, ladies and gentlemen. It's a pleasure to see you. And hey, things are moving right along.
Thank you, Congressman. And before we get started, Dr. Maya, you can go ahead and introduce yourself.
Hey everybody, my name is Dr. Maya, also known as Dr. Maya 100. This year, I'm also a Virgo. Shout out to all the Virgos. Yeah. Over here going 100 on community health. So excited to be here. Thank you, Nikki. Thank you, Congressman Davis. 2 other Virgos. It's no wonder why they had these. They're brilliant. You see what I'm saying?
Hey, I appreciate the pride, and we're not going to go there and have a fight about our signs. So I appreciate that, and I do want to, say to my audience, we appreciate you. I wanted to acknowledge all the way from New Zealand, we have someone checking us out tonight. So Dan Kiwi, used to be one of my favorite fruit, but nothing wrong with that. As a carnivore, I don't eat a lot of fruit anymore, but I just wanted to do a shout out. So we're going to kind of start our conversation. I'll just kind of tee it up, and that way we can talk a little bit about Prostate Cancer Awareness Month. And I think it's important. What I'll do is frame it through the lens of a metabolic doctor who understands that we need to understand the root cause of why we get sick. And then I'll let my colleagues kind of chime in where they would like. And I think the first thing that I want my audience to understand is that the way we think about cancer is starting to change. And we've been taught for years, when myself and Dr. Pete were at Xavier with Dr. Carmichael, we were told that cancer is a genetic disease. And that's been the historical perspective. But now they're saying, well, maybe it's not a genetic disease, maybe it's a metabolic disease. And I think that's good news. And the good news is that you can't change your mama and you can't change your daddy, right? although you can impact your genes with a good lifestyle. But what's easier is to, affect your metabolic function. And the best way to affect your metabolic function is actually what you put in your mouth. So one of the best ways to deal with cancer is to understand there are certain foods that will increase the growth of cancer while others won't. So one of the resources I'll put in the chat is a conversation I had with Dr. Paul Merrick, who him and his organization put together a monograph which listed the things you can do that's natural to reduce your risk for all cancers, not just prostate cancer. So I'll put that in the chat. It was entitled The Cancer Prevention Class with Dr. Paul Merrick, episode 163, just for your record, if you want to look that up on YouTube. Now, having said that, for prevention, he mentioned, and the video goes into treatment too, but he talked about 4 supplements that were helpful for all cancers. One was vitamin D3. We tend to recommend vitamin D3 with K2 these days, and we recommend about 5,000 a day. So you need the K2 to help take the calcium from your arteries, from your heart, and put it into your bone. We need to think about omega-3, 2 to 4 grams a day. We need to think about green tea. And you usually do about 1,000 nanograms a day of that. And then finally, melatonin. We think about melatonin for sleep, but it's also been known to help for cancer. You can take up to 5 milligrams a day. And the last thing is the diet. Now, if Dr. Terry Mason joins us, I'll ask him about his plant-based approach. And he is a urologist, so he definitely has an opinion. But in the world I live in, we recommend a keto diet for all cancers. And there's a simple reason why. And that's because cancer cells, based on the Warburg effect, really love glucose as their primary fuel. And there's 2 ways to get that glucose to turn into fuel. One is called glycolysis, and one is called oxidative phosphorylation. And the difference is that oxidative phosphorylation is more efficient at producing energy. That's using oxygen. And you can get like 32 ATP. And most of us know when you make ATP, that's energy. And we need energy to grow cancer. But glycolysis only produces 2 ATP. And cancer cells prefer glycolysis. It doesn't make sense because it's only 2 instead of the 32. But the way it works, without getting too scientific, is that glycolysis is a faster process for energy production. And cancer cells don't have time to wait around for oxidative phosphorylation. So even though it's more energy, it takes longer. And so cancer cells actually increase their ability to use glycolysis to make things grow and to spread their cancer everywhere. And the most important thing I can say about that is that if you have you do oxidative phosphorylation in the mitochondria, and you actually do glycolysis in the cytosol, the fluid around the mitochondria. And at the end of the day, you need to understand that cancer cells tend to have dysfunctional mitochondria, so that it's difficult for them to use oxidative phosphorylation, and it's a slow process. So I wanted to put that in front of you just to help you understand if you are thinking about a dietary approach to help deal with cancer and prevent it. This is one of the ways to do it. The only other thing I'll say is that you need to be in ketosis. When you're lowering your carbs, you don't always go into ketosis. So this is a 20 grams a day total carbs approach. You need to keep your blood sugar when you're fasting between 60 and 90. You need to keep your ketones, you measured in your blood, between 1.5 and 3 milligrams per deciliter. And then you also have to do a glucose ketone index, where you take the actual blood glucose divided by 18 and then divide that by the ketones, and then it'll give you a range. You need to keep that number less than 3. So I know there's a lot of data, but for those who need to hear that information, I wanted to tee up this conversation by saying that you can actually help yourself. And the last thing I want to do before I get my colleagues to join is there's 2 recommendations to learn about metabolic cancer. One is called a book called Cancer as a Metabolic Disease by Dr. Thomas Seyfried. And what I'm going to do real quick is share my screen, because the Metabolic Multiplier website has a way for us to confirm, because when I have to do in a large health system, I have to show science to support everything I say. So what I'm going to do real quick is share my screen so that we can show this information. This is so no matter if you're doing any type of diet that is considered like low carb or keto, you need to have data, guys, because the world does not understand nothing we talking about, right? So what I'm going to do is put this in front of you. This is called Metabolic Multipliers. So Tiro website. And for this website, if I just search, if I search prostate cancer, which I did here, there's 15 studies that show that this dietary approach has helped. Now, if I take that and change it to another condition like hypertension, right? It'll then show all the studies that are related to hypertension that that you can then use when you're talking to your family, when you're talking to your colleagues. And for hypertension, the list is even longer. So I just wanted to put this in front of you. I'll put the link to Zotoro Metabolic Multiplier. You can just search that. And any diagnosis that's related to keto, low carb, or even and carnivore, you'll find every study that's ever been done. So when you're trying to kind of, share this information, you really want to show science. And if you don't show the science, people won't believe what you're saying. So I'm going to stop there. I said a lot. I just wanted to tee up this conversation so people would have that information. Before we get started, I want to go ahead and say, howdy, beautiful people, to Josephine. We appreciate you saying that we're beautiful. We're doing our best. We use Noxzema. We eat right. We exercise. And so go ahead, guys. Anybody want to chime in and talk about prostate cancer?
Yeah, I want to jump in, and this is really more context than anything else, because you started with an approach and prevention. But I've said this before: cancer takes its name from where it occurs. Cancer is an uncontrolled growth of cells. It can occur anywhere in the body. If it occurs in the brain, it's brain cancer. If it occurs in the breast, it's breast cancer. If it occurs in the prostate, it's prostate cancer. But ultimately, it's cancer. And the treatments may vary, but it's the same general sort of disease moving forward. The other thing, African Americans are much more likely than others to not only get prostate cancer, but they're about 2 times more likely to get prostate cancer, to have prostate cancer. The point I want to make, that has nothing to do with being an African American. That is a scientific fact based upon a series of things. Genetics could have some bearing on that, could be some genetic, but it's more related to where you live and how you live. And most African American men are more likely to live in socioeconomically depressed areas, less likely to have access to healthy food, less likely to have a job or have an income that can sustain them and their families, under a lot of pressure and a lot of stress on a day-to-day basis just to survive and get by. And those things probably not only increase our risk for prostate cancer, but increase our risk for other diseases. They also increase the likelihood that we'll die before what our time is, just because we're African American men. But it doesn't mean it's because we're African American men. It really is predicated on the conditions where we live, work, grow, and play. And if those conditions are bad, you'd expect bad outcomes, and that's why we have the bad outcomes.
Yeah, I'm gonna just chime in, just say, Joe, that was excellent, and the idea that where we live, work, and pray, those are what we call social determinants of health. And why that's so important, because we know African men who have lower rates of prostate cancer than Caucasian men in this country. When they move to America and they presume the life of an African American man, their rates of prostate cancer exceeds that of white men and similar rates to African American men. So what is it? It's not about more so the genetic components, more about where we live, our shared experience, the foods that we eat, the amount that we work, the less access to healthcare. So those are the things that matters. And I can tell you from experience this week, I saw a gentleman who came in great shape in his 60s, great complete metabolic panel, looked great, and his PSA was close to 9. Now, what we say is PSA is a prostate-specific antigen. We know there was some confusing studies about 10 years ago that indicated that PSA is not the best test for prostate cancer. What we know is that that study did not have a decent amount of African-American men in that study. Also, that the other reality is it's the only test we have available to give us some clue who should be referred to the prostate specialist for biopsy, right? 0 to 4 is considered to be normal. Above 4, there's some concern. It doesn't mean you have cancer. But what I can say from my experience is that anything past 7, now again, I had a oncology mentor who once told me, if cancer is the answer, tissue is the issue. So no matter how high that PSA is, I need to do a biopsy and cytology. I need to take a piece of that prostate, put underneath the microscope to see what it is. Is it inflammation? Is it stones? Is it cancer? And so that was the discussion that I had with my patient this week to say, hey, everything else looked great. We got to look into this. At 9.9 is very suspicious, but I can't say you have cancer at this point. Got to send you to the urologist. Urologist has to do the biopsy. Then the biopsy has to be sent to pathology. And pathology has to confirm that diagnosis. So that I'll let my colleagues kind of keep chiming on with this. I think we're off to a great start.
Yeah, I got to piggyback on what you said. And now I'm going to speak to my experience as a recent prostate cancer survivor. And what you said, I can actually speak to in terms of my personal experience. About 2 years ago, maybe a little more, my PSA went beyond 4. It had been less than 4 because 4 is what they call the floor. Anything 0 to 4 is something that you don't really pay that much attention. But when it starts to rise and go over 4, but I also want to provide some additional context. While I was at Rush, I was involved in an international study of prostate cancer called the Selenium and Vitamin E Cancer Prevention Trial. And we recruited primarily African American men. So I talked a lot to men about prostate cancer, and I talked to a lot of men about their PSA. I saw several men, their PSA shocked me because you may have known. One said he had a PSA of 50 and never had prostate cancer. Another said he had a PSA of 30 and never had prostate. It's a screening tool. Is to identify people that are likely at risk to refer them to someone else that can evaluate them. So going on with my journey, my primary care doctor kept pressing me to go see my urologist, which I did. And once it got up to about 8. And he said, Joe, I'm going to do a rectal exam, which men don't like. And I understand why, because I've had a number of rectal exams. It's not pleasant, but it won't kill you and you won't die from it. But you might die if you don't get it. And he said he felt something, a little something. So then he said he wanted to refer me to get an MRI. An MRI showed that there was this mass, a quarter of an inch in the prostate. So then I went to get a biopsy. and they looked at where the area was. They took out snippets. It wasn't pleasant. Then they said there was cancer in that tissue. If there's cancer in the tissue, then there's cancer in the prostate. So then they sent me to a radiation oncologist, and we discussed my course of treatment. I had options. The options were that I could have what they call a radical prostatectomy, and that's when they remove the entire prostate. But that can lead to complications like incontinence and other kinds of loss of sexual function. Then I could have radiation and seeds and see what happens. Those are my two options. I didn't want to opt for a radical prostatectomy because I didn't want to wear the pins for the rest of my life. And I said I figured that I'll take my chances because it could come back. But had a radical prostatectomy, had a course of radiation, had seeds implanted in my prostate, had a course of radiation treatments. The last time I saw my radiation oncologist, he took my PSA. You know what my PSA was? 0.01. In my adult life, I've never had a PSA below 1. It's a screening test. Doesn't tell you anything. It tells you something is going on. If the numbers go up, something is changing. If they go up too high, we need to do more. And so it's important. One, did you have a healthcare home? Because you won't get the test if you don't have it. And you go through a screening and whatnot, but somebody will be monitoring your health and tell you when you have a problem. You need a healthcare home, and you need a primary care physician that you trust and you can listen to. And, things should be all right. And maybe you can live as long as me and even as long as Congressman Davis. But if not, you might not make it that long.
Yeah. Well, I just like just to throw in it a little bit different perspective in terms of some of the things that I've been reading, and that is that prostate cancer is on the rise, and the prediction that over the next 16 to 17 years, that the rate will increase, and there'll be at least 700,000 more men that die yearly from prostate cancer. So there's that, that tell us that there's something bad out there. And we need to do everything that we can on every front that we can to deal with that. And so we need to address it in terms of what we can do to prevent it. And then the other thing, to address it in terms of doing the screening test so that we can detect it as early as possible. Because with most cancers, if early detection gives you a much better opportunity for a cure. Late detection mean bad diseases and tend to go along with bad outcome. So we have to really make certain that we are really educating the public and making certain that people are getting, hooked up with their primary care doctor, and that those primary care doctors are doing the screening and getting these people directed to where they need to be, so that if additional diagnostic studies are indicated, that they are done. As I said, we don't have a definitive test that we can do this test and we say, yeah, you got the screening test is not a definitive test, but if that screening test, which is the PSA, is abnormal, then additional evaluation is needed. And Brother Harrington talked about getting a rectal exam and then a possible prostate biopsy. So we need to make certain that men understand this. And even though there is some discomfort, this discomfort is much milder than metastatic cancer. The uncomfortable pain and those things that are associated with metastatic prostate cancer is much worse than the rectal exam or the prostate biopsy. So we need to make certain that that men in our community, and I think one of the other things, I don't know if this is still the general, is that the African American men tend to also get prostate cancer at an earlier age than men of other races. So we need to make certain that we're screening them. I think the general trend had been 50, but generally African American probably should be screened about 45. And if you have a family history of early prostate cancer, that should also be considered.
Dr. Mason, I want you to provide some commentary, but I thought it was kind of funny to see this comment. Just getting here, are these speakers carnivore? And that's because I'm sharing this on my YouTube channel. So a lot of people who follow me are low carb, keto, or carnivore. And I thought it would be a perfect time to let you introduce yourself, Dr. Mason. And I'm pretty sure you would answer that question. No, I'm not a carnivore, but I think and for my audience who's following me, this is a forum where my colleagues have different dietary patterns than I do, but I feel it's important that we all kind of have conversations together. I think Democrats should talk to Republicans and independents, and I think that low fat people should talk to low carb people. So Dr. Terry Mason, this conversation has been about prostate cancer. I kind of teed it up with some thoughts around keto and how it would benefit people. You're a urologist to the stars, as Nikki would always say. And I'm curious if you can introduce yourself and then from your perspective, share, obviously you're more plant-based, but share anything you'd like to share today. And let me make sure we get you unmuted. Hold on. All right, there you go, Doc.
All right. Well, thank you very much, and I'm always grateful, even though tardy, to get on the broadcast. And yes, my name is Dr. Terry Mason. I'm a retired board-certified urologist, and I practiced urology over 20 some odd years here in the city of Chicago, right on the South Side. And I would say that the most of the people that I saw, very few, especially at that time, were plant-based. Now that has been some time. I've been out of practice now, oh my God, over 10, 15 years or more. And since that time, I've learned a lot myself. And just as a disclaimer, I am a plant-based person. And I do recommend being plant-based as best as you can, but if you're going to do it, make sure you're not getting foods full of pesticides and all kinds of other things. Make sure you get them as good as you can. And in terms of whether or not that's going to protect you from prostate cancer, I don't think there's any data that supports that it will protect you. However, Dean Ornish has done done some studies, and what he showed in men that he was treating for prostate cancer, he did put them on a group on plant-based eating and another group that were eating regular food. And he did a lot of studies looking at genetic markers and all kinds of things. And I can just say that, and also included things like meditation in the one group. So they got the plant-based food, they got meditation. They also got some other kinds of supports. And in those patients, now, these are patients who have prostate cancer. So I'm not talking about preventing. These are persons who have prostate cancer. And if you want to see this, if you want to see it, one of the places that you could go is a source that I send a lot of people to, and that's to nutritionfacts.org. That's Dr. Mike Greger's site. And those things are there if you choose to look at them. But he did show that people who did eat plant-based, and again, this is a small study, and you need much larger studies to validate these things. But he did show in that group that a number of their markers, some of their genetic markers and some of the other things, and he has in this one particular paper, he actually showed the difference between serum, that is, if you take the blood and spin it down and separate it from the groups of people who were following this plant-based eating. Again, it's a small study and it needs to be repeated, then looking at what happened with things like the ability for this blood to actually create a more or a higher incidence of the prostate cancer cells growing than in the ones that were eating, the plant-based ones were eating, the plant-based ones had a lower numbers of new prostate cancer cells compared to the ones who were not. That also included meditation and some other things. So what we need to do is really look at this very, very closely. I do not say The thing is that what you want to do is what you heard earlier, is you want to get the screening, because in God we trust, all others must have data. So get the screening, find out if you have, and the only way to find out if you have prostate cancer is you have to get a biopsy, and your biopsy has to be done by a urologist. And for the most part, the biopsies, not 100%, but they're the best thing that we have for right now for determining that. So I'll stop right there. And there are a number of things coming out, and we're not going to get into a plant-based versus. I have not eaten meat. I was a big meat eater a long time ago. I used to eat a steak every single day, 7 days a week. And I chased my steak with pizza from a nice, well-known pizza joint. And I was eating pizza with beef crumbles on it and all kinds of things, and with too much of frequency. And that bought me a trip to I didn't get prostate cancer, but I did have a trip to the cardiologist and ended up with 3 stents in my heart. So I think that there's, and I've done a lot of talking, and I'll stop here in a moment. I've done a lot of talking to people about prostate cancer, and I tell the guys, look, your heart is going to kill you way before your prostate will. So if you want to be clear about something and look at where there may be some benefit to plant-based eating, it certainly is potentially in so-called heart disease. So I'll stop right there.
And before my colleagues comment, I want to say now Dr. Mason has provided cover for anybody out there who wants to do a plant-based diet and use that approach. I've provided cover because he said he hasn't eaten steak in years. Well, I eat enough steak for everybody on this panel. In fact, I'm eating steak tonight. So I think that, and I provide cover for people who are trying to do keto and carnivore. The good news is they have things in common, right? And what they have in common is that we're eliminating processed food. That's going to help save your life. We're eliminating all of that added sugar. That's going to help you live longer. And we're eliminating all those processed grains. So that's going to help you live longer. So there's a lot in common. And if you eat real food, I think you're going to do better. So that's why I think it's important you have a low fat and a low carb guy on the same platform to provide cover. Because if you change your diet to a whole foods diet, and you start moving your body and you reduce your stress and you get enough sleep and you get around people that's getting on your nerves, who are stressing you out, all of those things are going to probably reduce your risk for cancer as well. So I'm going to let my colleagues comment.
I want to chime in. I want to go back to something that Dr. Miller said. And you actually echoed it too, in terms of we're living longer. So that increases the pool of men who can actually get prostate cancer if we're living long. The only way the population grow is at the end and at the beginning. And so if we're living longer, then that creates a greater pool of people that can die from these things. And there's a diet component to everything that we're talking about. I'm not going to tell you which diet, but you need to eat a healthy diet if you want to be healthy and you want to live longer. What I'd like to hear is Dr. Maya. Dr. 100 is the only woman here, but she is a doctor. And I don't want, because she'll go back and tell her sisters that they wouldn't let me say anything. It was just all these men, black men, and they wouldn't let the lone woman in. And I don't want that to be said of me.
All right. Oh, well, thank you, Mr. Harrington. One of the things I try to do is like, hey, I let the people lead. There's a lot of people out here that on here that at some point in their life had prostate. So I'm like, they will be the expert. So, and then we have Dr. Mason. So, Mr. Harrington, what I was thinking about doing, especially when it comes to during this time we have Dr. Mason here, is just kind of reviewing what happens if I'm a patient, So what happens if I'm a patient? Because a lot of times, one of the things that Dr. Mason stresses is like, by the time you see Dr. Mason for it, we're considering a problem. So, Dr. Mason, let me know and let me know what can improve. I'll tell you what I tell the people with prostates that I'm so lucky to work for, a lot of people I work for diverse people, but vast majority of the people I work for are African Americans or people of African descent. And so what I usually say is, hey, I go over what has already been said. Prostate cancer is actually, it used to be the most common non-skin cancer in the US. Now it's the second most common. Breast cancer this year, at the end of 2024, they anticipate that breast cancer will be the most common, with prostate cancer being the most common non-skin cancer in the United States, with close to 250,000 new cases diagnosed every year, but approximately 34,000 deaths. So of those 34,000 deaths, because we just talked about, who's getting diagnosed, but who's actually suffering the consequences. African Americans are 50% more likely to develop prostate cancer than our white men, than our white peers. Twice as likely to die from prostate cancer. So being diagnosed, and prostate cancer, they always teach me, oh, it's a slow growing cancer, things like that. Being diagnosed, but then all tripping up in that system, there's for a lot of people a long road between diagnosis and death from something, right? So the nuances within the system have an opportunity to benefit from what Dr. Pete said, which is increased and Mr. Harrington, which is increased efforts to navigate social determinants of health, right? And then what Dr. Miller has already said, I tell my patients, men with a family history of prostate cancer need to be screened earlier, right? Because they are called higher risk. If you have a brother, a father, someone with a history of prostate cancer. And then I tell my people, Dr. Miller, to start prostate screening at 40 years of age. That's typically, like they say 50. For African American men or men with a family history of prostate cancer, start at 40 years of age. And then we go over the treatment, which I think Dr. Hampton, you've gone over, but we also go over preventive ways. So, hey, we're going to screen starting at 40. We have the blood test. For me, I was raised on physical exam. Blood test every year is kind of cute. You got to do that digital rectal exam. At some point you still have to get it, and then I always tie it in, Dr. Mason. I've been telling people that things they can do, say you don't want this, say you don't want prostate cancer. What can you do to help your body not get it? I've been telling people more fruits and vegetables. I've been telling people stay at a healthy weight, limit your alcohol intake. And if you are a person that smokes cigarettes, from what I've understood and from what I've learned in the books and the literature, there is a link between cigarette smoking and development and aggressiveness of prostate cancer. And then we have that discussion. We continue to have that discussion. I tell them, in addition to that, let me know if things are happening different for you. You're noticing blood in anything that comes out the penis area, in urine or semen or sperm, if you're noticing blood in there, if you're noticing changes in your stream. Now, that could be, that doesn't have to be prostate cancer. It can be enlarged prostate, but changes in stream, changes in frequency, blood in stream, mucus in stream, and changes in the, the magnitude of erection. Come back, let's talk about it. And then we go from there. So I actually start talking to people at 30. I let them know that we're going to start screening at 40, so they know.
Yeah,
you can't spring a DRE on people. No surprise,
I want to piggyback on something Maya said. She made me remember something. If you're waiting for a symptom, you're playing Russian roulette.
Yep.
By the time you have a symptom, whether it's cancer, whether it's any kind of disease, you're in big trouble, because that means it's at an advanced stage. And that's what a lot of people do. And a good friend of mine and Dr. Terry Mason's, Paul Crawford, said Black people suffer from the I feel good symptom. James Brown, so I feel good, so I must be okay. That may not be the case.
Also, sorry, Dr. Mason, I forgot. Oh, you're on mute. But I got one more. I forgot. Before you tell me how I did, I forgot other things, changes in you're sweating, you're losing weight, things like that. I also include there. Still on mute, Dr. Mason. Dr. Hampton, do you have the, okay.
I'm not muted. Am I on now?
You good, Doc?
Okay. No, I was going to say, in general, I want to follow up something that Joe said. That's really because we have been programmed to think of symptoms when we come to disease. Doesn't matter which one, but we've been programmed to think of that. We talk about the 4 symptoms of this or the 5 things of this. First of all, there is no disease and I want to underscore what was said. There's no disease that presents a symptom in its earliest, most curable stage. So that's why we don't test. I mean, that's why we don't guess, we test. And that's why. So if you're sitting there, well, I'm peeing okay, I can have sex okay, I'm not bleeding, I don't need to have any of that stuff. No, you do. Because that doesn't mean anything. You could have all that stuff and you could be totally free from all those things. So don't get caught in this stuff about symptoms, because for early prostate cancer, there are none, period. Just think of it that way. There are no early symptoms. And in terms of, some of these other things that people, I've heard all kinds of things. And sometimes you get a group of men together and you get a group of folks of the blind leading the ones who can't see. So we need to make sure that you're getting reputable information from people who know what they're talking about. And I've seen a lot of it in my practice over the years where that kind of thing happened. And so and this goes for women too, because there's a lot of diseases that women get that you shouldn't wait till you have blood coming. I mean, other than menses, to think that you should go get a pap smear. And I don't want to go off on a tangent, but I'm just trying to make the point that we need to get out of this symptom-based thinking. Now, if you do have a symptom, definitely get it checked out. But if you don't think that everything's fine.
So thank you, Dr. Mason. I know we're near the hour, so since I want to make sure we honor the time, I want to start the process of letting everybody kind of provide some final thoughts about this topic or anything that may inspire the many people who will hear this message. And as we honor prostate cancer awareness, and we'll talk about sickle cell in the near future as well, because that's happening this month as well. It's just important that we leave people with a message of healing, a message of hope. I'll just say from my perspective, as we start, I think that a lot of what I try to tell people is if you give your body the foundational tools to heal, you'll give yourself a chance. And I can't promise you that you will cure something if it's already started. But what I can promise you, if you feed your body the right fuel, your chances of getting these cancers will go down substantially. And your chances of healing or even delaying cancer from taking you from this world, you're going to be more effective. What you got to do is, if a person has surgery and they go home and eat garbage, they don't follow the instructions of the surgeon, there's a good chance they're going to have a complication and they're going to end up in trouble. So we have enough information out there to help us, to guide us. We kind of know some of the stuff. We mentioned cancer earlier as one of the things that can increase your risk. So you got to ask yourself, why am I smoking? If you're still smoking, I get it. It's more addictive than heroin and crack. But there's help out there, and there's plenty of people that look like you, sound like you, talk like you, live in your neighborhood who have overcome these addictions. And because of that, they will be here longer with their family. So I want to encourage everybody who's hearing our voice tonight, let's take ownership. Let's be accountable, and we're not going to be enablers. So if you have a family member who's struggling, who maybe is the smoker in the family, I'm not going to get your cigarettes. If you're going to get some cigarettes, it ain't coming from Dr. Hampton. Those are the types of things that we don't want to be enablers, because we want to be nice. Enablers are some of the nicest people on the planet, but they make some of the worst decisions and they don't really help our family. So I'm going to pray that you all hear that message. So let's go to Dr. Graham. What's your final words for the night, my friend?
Well, I want to express my appreciation for Joseph Harrington, expressing his experience to undergo treatment. I just had a neighbor, 72 years old, who went through something very, very similar. And I was really surprised. He didn't miss a day of his life. He wasn't sick. He kept doing what he wanted to do, lived the life he wanted to lead. So one of my concerns is learn about the treatment, because you don't have to be afraid to get tested when the treatment isn't as bad as you think, and you'll be okay.
Right. So let's go to the very insightful Joseph Harrington.
I'm going to take a step back and use something that I developed when I worked for the health department in the 1980s. I was managing a citywide program focused on blood pressure control. And hypertension is called the silent killer for a reason, because it's asymptomatic. Even though people say they know what their blood pressure is, it's asymptomatic. But it will ultimately cause a heart attack, stroke, or kidney failure. Those are the three outcomes relative to hypertension. So we came up with this tagline: what you don't know can kill you. And I'll add to it: don't guess, test.
Thank you so much. Dr. Miller.
When it comes down to cancer, one of the big things that everybody, when we speak to the general population, is fear. I'm afraid. People get afraid to get tested, afraid to have this disease, and so they delay whatever care that they need, because they think that's. I'm sure they don't think that not doing anything is going to be helpful, but the fear paralyzed them. So I would say, don't let fear paralyze you. Regardless of how afraid you may be of a disease process, if you don't do anything about it to stop it, certainly it's not going to stop on its own. And your only chance to inhibit it or to stop it is to be proactive and to do whatever can be done to treat it.
All right, let's turn to Dr. Pete.
So until next Monday, I would just say to my colleague, Dr. Miller, 2 Timothy 1:7 said, God did not give us a spirit of fear, but of love, power, and of a sound mind. And while I don't force my religion on anybody, but I do believe my presence should represent a sense of calm and confidence, that we're not going out without a fight. So to the extent that we think cancer is the answer, we got to get a tissue sample. And if there's an abnormal PSA, the first thing we're going to do, we're going to get that referral going to get you into the urologist's office, like Dr. Mason, to then get us a confirmed diagnosis. And then we have a list of options that we have. The earlier we find out, the more options we have. I can tell you that sometimes people over rely on the test as opposed to your lifestyle. And when I hear low fat versus low carb, I hear anti-inflammation. You want the lowest amount of systemic inflammation in your body. How do you do that? Low stress, lots of sleep, being around people that love and care about you, laugh a lot, okay? Eat lots of vegetables, okay? Eat less processed foods, okay? So that's what I hear, low inflammation. So this is not like contradictory. This is actually consistent, right? And so, as a primary care doc, front lines, I see a lot of the normal people that walk in, that great weight, and the whole nine, and next thing you know, PSA is 15. We don't know. You got to come in and let's do the test. Let's see what happens. And guess what? A 15 don't mean you're going to die. It means now we know where we are. Let's move from here. And it does mean maybe it's an acknowledgement that maybe you've overexposed yourself to a lot of systemic inflammatory agents. Some of it's stuff that we can't control, like racism and lived environment and stress and this folks killing each other and all the rest of that. But we can change what foods we're exposed to. we can change the people that we are around to laugh and to have fun. Okay, go to church or synagogue, wherever you go, mosque. Okay, and then live a very positive life. Stay with your PCP and let us help you to guide you through this process. And there's some great urologists out there. Dr. Mason's one, but he's trained so many young ones after him. So I'm referring my patients to him and Dr. Hollowell and a bunch of other people who take very good care of my patients.
Well stated, my brother, and quite inspirational. Dr. Maya, you're until next time.
Yeah, I guess until next Monday, I want people to realize how valuable you are. And no matter, thoughts come, thoughts go. Everybody's had thoughts that, hey, what is my impact on the world and everything, and we've all had moments where sometimes we can't see it. But definitely you matter, you matter to us, you matter to someone. So definitely it's important to take care of yourself, put your health as a priority, and handle anything you can. Like they said, get your screenings. Why? Because you need to know what's going on before it gets so bad. We need you whole and safe so that you can accomplish your purpose that was put in you, right? So it's our purpose to help you stay safe so you can accomplish your purpose, and the cycle goes round and round. We'll see you next Monday.
Well stated. And Dr. Mason, you're until next Monday.
Well, first of all, let me clarify. I'm not in practice. I do not see patients. I am a happily retired urologist. So I just want to make that clear. Second, and the next point is, one of the things that we did while we were when I was in practice that I thought was very, very helpful is we started a support group, because there's nowhere for people to go and talk. You just say go talk to people, but you need them to be able to talk to people that can give them the right information and not scare them or give them some bad information. So that's something we should probably talk about. We used to have the support group was called Us Two, and the other one was a prostate cancer survivors group, and we brought the wife and the patient together, and they shared from each other, and it was a national organization for a long time. I don't know if they're still out there, but maybe that's something we could talk about in terms of support, not just for prostate cancer, but when you feel like you're by yourself, that you're going through this by yourself. And even when we had our erectile dysfunction group, we put a support group together for that, because we wanted people to feel like they weren't alone, that this is something that happens to a lot of people, and it happens to me, and it could happen to you. And here's how I'm dealing with it. And there's still probably, Billy D's videos, Billy Davis, Marilyn McCool's husband, he did a wonderful video for us. And I don't know if it's still out there, but he did. So we should think about that.
Well stated. I enjoyed this conversation. You never know where it's going to go, but I really appreciate all of my colleagues, ladies and gentlemen. Let me emphasize ladies. And I want to do a shout out to Nikki, absolutely, who is our host and who's not here because she was celebrating her birthday. So shout out to Nikki. Hopefully she's being legal out there and doing legal things for her birthday. Amen. And then we want to, again,
not too much on my girl.
Yeah, I know. I gotta go at her since she ain't here. You know what I mean? But and of course the congressman. Happy belated birthday. Just imagine a guy that's 83 and still doing this community service. It's actually quite mind blowing, because I see people who are that age and they can't even get out the chair, let alone be a leader in this country. So I want to do a shout out to him creating this forum. I thank my frat brother Pete for inviting me to join, and it's been a nice ride. So for everybody, until next Monday, have a great evening. My colleagues, you guys have a great night, and we'll see you guys next week. Take care, guys.
Bye-bye.